I would like to call our last speaker, Dr. Prajakta Ranade ma'am, consultant pediatric rheumatologist at Cloudnine Hospital and Sakra World Hospital, Bangalore, who with her knowledge and experience in this field will help us to navigate the latest diagnostic and therapeutic strategies for IgA vasculitis. Thank you.
Good afternoon, everyone. Firstly, I'd like to congratulate Debashish and team NCPR for orchestrating such a wonderful academic feast for all of us. And I would like to express my gratitude to Dr. Kupchandani and my colleagues in Bangalore, Dr. Anand Rao and Jyoti, to be kind enough to share cases today for us to learn from their experience. So this is the outline of my talk today. So by now, we all know when it is HSP or IgA vasculitis. So palpable purpura and joint pain are the commonest symptoms with which the patient is going to present to us. And then as a clinician, the onus is on us to dive deep to look for the other systemic involvement which are going to contribute to the long-term morbidity and mortality in these patients. So the onus is on us to look for GI and renal involvement or any other systemic involvement. So despite the fact that most of these children will respond well and have a self-limiting disease course, we know that acute and chronic complications are expected. Most of the acute complications are because of the gastrointestinal involvement. So it could be in the form of severe GI vasculitis, perforations or intussusceptions. And the renal involvement is the single most important factor that's going to determine in the long term the prognosis of these children. And about 1 to 5% of these children may end up having chronic renal failure in the long term. In the year 2019, shared recommendations were suggested for diagnosis and management of children with IgA vasculitis. And before this, a lot of recommendations were extrapolated from the adult IgA vasculitis or sometimes with IgA nephropathy. So now we have pediatric specific recommendations and we use this by and large for our clinical practice. So we'll discuss few of the clinical features in a case-based way. So first case is a 6-year-old boy who has presented with typical palpable purpuric rashes and arthralgias. His blood pressure was normal. How the parents are really worried about the scary looking rashes and the child is in severe pain. So how would you manage at this point? So despite the fact that the rashes are very scary looking, and for parents especially that's the point of concern, it is our duty to ensure and reassure the parents that these rashes are usually self-limited. I'm talking about the classical HSP where the rashes would wax and wane for 4 to 12 weeks period and then it will subside over a period of time. But we need to ensure that this child is kept under surveillance and monitored regularly for the underlying renal involvement, which may not always be apparent, especially and can present in the first 6 months after the onset. So we are going to treat the rashes symptomatically and look for the other systemic involvement and keep the child in surveillance for the next 6 months. And I'll talk about how to monitor these children in the long term over the next few slides. But it's not always the case that we have the classic HSPs, and then about 1 to 2% of these patients will present with atypical, and by atypical I mean they could be atypical in nature by being bullous or hemorrhagic rashes or sometimes being necrotic rashes, or they could be extensive, so not limited only to the lower limbs but might extend to involve the upper limbs and sometimes the entire body. So though atypical presentations are not as common as in children as we see in adults, but these children have need a special mention because they will have a different course compared to the other garden variety HSP. So of course when we are looking at such severe rashes, we need to rule out other differentials as we just saw in the previous talk, and therefore skin biopsy becomes mandatory. So atypical rashes are definite indication to do a skin biopsy. What are we looking in the skin biopsy? Are leukocytoclastic vasculitis changes with presence of IgA deposits. So in about 80 to 90% of patients, we will see the presence of IgA deposits, but the absence of IgA staining will not exclude our clinical diagnosis of IgA vasculitis. Also remember to biopsy the most recent lesions, and sometimes you will have to take 2 punch biopsies, one for the immunohistochemistry and one for the histopathology. So that is one practical point. There can be certain other conditions which can cause IgA deposition and that needs to be considered. However, remember that it is not necessary to do renal skin biopsy in all the children who are presenting with the classical palpable purpura. So in this child, the biopsy proved that it was IgA vasculitis. How do we manage further? Because this girl had very severe involvement, it is of utmost importance that we ensure that the child is hemodynamically stable, he is covered for infections, and we manage the blistering lesions. And of course, this mandates the use of corticosteroids, and we could choose oral versus intravenous based on the other clinical features. So if there is GI involvement, definitely warrants giving IV pulse methylprednisolone will definitely help. Otherwise, if the child is stable, oral steroids with a slow taper could help. Now, there are a lot of reports when these atypical features are not responsive to steroids. So there's definite role of other medicines like dapsone or colchicine. So they can be tried in patients who have persistent or recurrent skin lesions, or the ones which are not responding to steroids. So a few practical points with dapsone are always rule out a G6PD deficiency before starting dapsone. Start at a very low dose, increase gradually, and keep a check on hemolysis or methemoglobinemia. Also remember, when we have atypical features, also think of extended spectrum. So these children who are often older have very severe GI or renal involvement, and they may have presentation not limited to these organs, but could have extensive involvement. So as was seen in this case, this girl, in spite of treating with methylprednisolone in the beginning, she had kidney involvement, but apart from that, her disease was very severe, and she also had pulmonary thromboembolism. So in an older child with atypical features, always look for atypical presentations and always look for more severe manifestations. As far as the musculoskeletal system involvement is concerned, most of the times it's arthralgias. Occasional patients may continue to have a short course of arthritis. They can be treated for pain relief with NSAIDs and ibuprofen. Be mindful for looking for active GI bleeding and severe renal involvement before starting NSAIDs though. Moving on, case 4, these are the two clinical features where genitourinary presentation had preceded the onset of rash. So the first picture here is a presence of penile edema. So the child was referred by a pediatric surgeon with penile edema, and there was no other palpable purpura or other feature in the beginning. So we asked the child, treated it symptomatically, and asked him to follow up in a couple of days, where then he had developed florid palpable purpuric lesions. And in the second picture we see classic epididymoarchitis. It is seen in about 10 to 20% of cases with IgA vasculitis. Definite role to do a sonography to rule out a testicular torsion, because that is a surgical emergency, and presence of epididymoarchitis in HSP definitely warrants for the use of corticosteroids. Moving on, case 5 is a 5-year-old boy. He had presented with rashes over his legs, swelling of hands and feet, abdominal pain, and he had scrotal swelling as well. There was a history of upper respiratory tract infection a week ago. His BP was normal and Kawasaki was ruled out. So as you can see, he had inflammatory edema involving hand and feet, and he had palpable purpuric rashes as well. So the child was treated initially symptomatically, but his abdominal symptoms continued to persist, and the child was in severe pain. So at that point an X-ray was ordered, which is showing multiple air-trapped bowel loops. However, there was no air fluid level. The child's inflammatory markers were mildly elevated. At this point, practicing pediatrician had ordered for a CT and a sonography, which was showing circumferential thickening in the ileum, in the sigmoid colon, and the child was then further referred for management. So this child had IgA vasculitis with severe GI involvement and epididymoarchitis. Now, when we have a clinical scenario where there is severe GI vasculitis, we often as clinicians are at, walking on a tightrope to decide whether to escalate the immunosuppression or to rule out perforation and intestinal obstruction. So it is wise to involve a pediatric surgeon at this point in time, definitely rule out an obstruction or a perforation. But because this etiology is driven by inflammation and vasculitis, giving immunosuppression in the form of pulse methylprednisolone will definitely help in improving. So he received pulse methylprednisolone followed by a short course of oral steroids, and we kept on monitoring him for renal involvement in the long term. So for the GI features, mild or the short-lived ones can be managed symptomatically. For the severe abdominal pain, GI bleed, do a sonography to rule out intussusception, involve a pediatric surgeon to ensure that there is no perforation or obstruction, and sonography thus plays an important role before we proceed. And definitely we should consider giving injectable methylprednisolone compared to the oral ones for the increased poor absorption sometimes with GI vasculitis. Now, as yesterday was, it was highlighted by Dr. Foyle that sometimes when we have a very severe GI involvement, rituximab may dominate over cyclophosphamide, and therefore rituximab would be a second choice if we have to use in this case. Moving on, This is the last case. There's a 14-year-old boy who had presented with loose motions, vomiting and abdominal pain. He was managed as bacillary dysentery at the local place, but his symptoms didn't improve, and then over a period of time he developed joint pains, initially in the lower limbs, extended to the upper limbs, and he had a typical palpable purpuric rash. Initially it was only with the lower limb predominance, extended to upper limbs as well. So he was diagnosed as HSP clinically, had received oral steroids. So for next 2 or 3 days he was symptomatically better, but he developed blood in stools. And subsequently the pediatrician had suspected IBD, and with that he had given a pulse methylprednisolone. So he did improve symptomatically with methylprednisolone, but in the few days later he still persisted to have bloody diarrhea, abdominal pain, joint pain, and at this point a CT was ordered, which is showing 15 to 20 centimeter thickening of the ileum with some mesenteric congestion. So with the diagnosis of HSP, GI involvement and perhaps extended spectrum, he was referred for further management. So in the pediatric rheumatology clinic, he was pale, he was having edema, but he was hemodynamically stable by then. And the initial examination showed microscopic hematuria, there was albuminuria, and the tests done to rule out the other connective tissue disorders were negative. Remember, this was a 14-year-old boy. So at this point, a diagnosis of HSP with severe GI involvement and perhaps a nephritis was also made. So the next logical step here was obviously to do a renal biopsy. So in the SHARE recommendations of 2019, there are certain absolute and relative indications to do a kidney biopsy in a child with IgA vasculitis. So any persistent or severe proteinuria, decreasing eGFR, decreasing or worsening renal function, and nephritic or nephrotic syndrome will definitely warrant a kidney biopsy. What are we looking at in the kidney biopsy is presence of a proliferative glomerulonephritis and deposition of IgA. But oftentimes what happens is pathologists may use only the ISKDC classification to classify the kidney biopsy findings, and as was also done in SHARE 2019 recommendations. The only drawback here is the ISKDC and the SHARE recommendations are mainly focusing on the glomerular changes, and sometimes the mesangial changes or the tubulointerstitial changes are not given that weightage to classify them into categories of nephritis, and this would definitely determine the outcome in the long run. So that is one thing. So the other solution to that is to incorporate the Oxford classification to the ISKDC classification criteria. So as far as the management of IgA vasculitis nephritis in children is considered, there are SHARE recommendations obviously, but there are also, initially we used to use the KDIGO recommendations. There are certain differences in the management according to SHARE and KDIGO. So based on the percentage, the duration and the severity of proteinuria, eGFR and the number of crescents, we are going to classify the nephritis as mild, moderate and severe, as is seen here. So in this child, the biopsy was done, diagnosis of IgA vasculitis nephritis was confirmed, and he was then pulsed with methylprednisolone and also was pulsed with cyclophosphamide. Then followed by that, he was kept on oral steroids, and an ACE inhibitor and ARB blocker was added. The point that I want to highlight here is it is of utmost importance to add an ACE inhibitor in any child who has proteinuria and IgA vasculitis. This is definitely going to help with the renal remodeling and is going to determine help in the long-term outcome of a child with IgA vasculitis. So for this child, in the next 3 or 4 months into the illness, he was continued on pulse cyclophosphamide. A check on cumulative dose was taken since he was an adolescent boy, and then subsequently when he was in remission, he was shifted to azathioprine. Steroids were gradually tapered over the next 1 year, and the ACE inhibitors and the ARBs were continued. His urine had normalized, the PC ratio was normal, and his blood pressure was normal. So he was in remission. This remission was then maintained with azathioprine, and ACE inhibitor was continued for the next 2 years. During this time, the eGFR and growth have been normal. In the next 1 year, this child was kept under close monitoring with monthly follow-ups where we measured the blood pressure, eGFR, urine routine microscopy and urine proteinuria. However, over the next 4 to 5 years, this boy had become an engineer, he got a job and he shifted to Germany. And by the year 2022, as a part of routine clinical examination, he got his blood pressure checked, and at that time it was noted that he was hypertensive, and that led to further investigations only to find that his creatinine was 3.7, eGFR was 27 by then, and currently though he is symptomatically well, but he is under nephrology care. So the point that I wanted to highlight is we often tend to manage very aggressively in the beginning, and during the whole process when they go in remission, it is often, on our part as well as from the patient's perspective, we often feel that, the storm has calmed down, but sometimes the silent diseases may continue, and this is a very unfortunate event where, we don't want to land up in similar circumstances. So it is, whenever the child is in remission or we are transitioning a child with IgA vasculitis, particularly nephritis, we should counsel the parents about measuring blood pressure or getting a urine analysis done in the long term. So share recommendations are readily available for the management of IgA vasculitis nephritis, and it's mainly that whenever the proteinuria is persistent, we definitely start ACE inhibitor and continue it. For the moderate and the severe IgA vasculitis nephritis, pulse methylprednisolone and sometimes a pulse cyclophosphamide followed by a second immunosuppressive agent in the long term is definitely indicated. How do we monitor these children? So any child in whom we are making a diagnosis of IgA vasculitis, we have to ensure that we take time to counsel the parents that the child needs to be monitored to look for renal involvement over the next 6 months. So it may happen that the child may not be symptomatic, but the urine analysis could have mild proteinurias, and that itself could have long-term outcomes. So we are going to call the child for weekly visits in the first month, fortnightly visits in second and third month, monthly visits for 3 to 6 months, and then follow up for reassessment at 9 and 12 months. At each visit, apart from clinically examining the child, we are going to check the blood pressure, calculate the EGFR, ask for urine analysis, and look for protein in the urine. Now, about 1/3 of these patients, in spite of being treated well, may have a relapsing course. The relapsing or recurrent disease is most commonly seen in older age at onset, so notably after 8 years of onset, and if they had very severe presentation in the earlier. So the children who had presented with severe GI involvement or severe renal involvement tend to have a recurrent or relapsing course. And most of the times the relapse could be preceded by an upper respiratory infection, notably streptococcal. So I've just emphasized for the long-term prognosis, and to summarize, skin limited, we can follow up only systematically. Atypical definitely warrants steroids. Joints can be treated symptomatically. Orchitis and abdominal symptoms definitely warrant for steroid use. Abdominal symptoms always involve a pediatric surgeon to rule out intussusception, and other system involvement like CNS vasculitis or pulmonary hemorrhages need immunosuppression, and we discussed about the nephritis depending upon the degree of involvement. So the definition, so the indications of corticosteroids have been given, but I want to highlight here is that there is no role of giving prophylactic steroids to a child in whom we have made a diagnosis of IgA vasculitis of a typical type. So if the child has purpuric rashes, has musculoskeletal features, does not have GI or renal involvement, there is no role of giving steroids to prevent renal complications. A word on IgA nephropathy and IgA vasculitis. So oftentimes in most of the articles, these words were interchangeably used and added to the confusion. So there can be two takeaway messages from here. One is they could be perhaps a part of the same clinical spectrum as we discussed yesterday with Still's disease, but we should note that IgA nephropathy is usually seen in adults. It is a renal limited disease as against to IgA vasculitis, which is seen in children and adults, and lot of extrarenal features are there. There are what is new in the business. So basically we have a lot of biomarkers available to ensure that we avoid kidney biopsy and still know whether there is renal involvement, and few of the targeted therapies can be used. The intention of these is mainly to either reduce the production or the deposition of the IgA into the blood vessels. So a lot of IBs and MABs and a lot of biologicals are being tried. I'm not sure how many of them have been tried in pediatrics, so that we don't have much of data from that perspective, but these are the ones which have been in the recent evaluation. Thank you.
Very nicely elaborated by Dr. Prajakta.
Thank you.
Actually, I have a similar case. That case actually presented first with severe abdominal pain. And endoscopy was done where purpuric patches were seen in the stomach, duodenum, extending up to duodenum. And after that, actually, we put her on steroids. So after 1 week, the steroids were tapered and stopped after 2 weeks. And third week, when the child presented again for urine analysis, the child had protein 3 plus, and 24-hour urinary protein was also more than 1 gram. And I had that doubt on this share criteria actually.
Hello.
That should we wait for 4 weeks for doing kidney biopsy, or one should do at that time actually?
So as far as the diagnosis is concerned, it's going to be clinical. So presence of IgA vasculitis nephritis is based on clinical diagnosis. But we want to do a kidney biopsy from the long-term perspective to note how severe was the disease, because the therapy between mild and a moderate to severe nephritis would differ. So if we are, and as was discussed yesterday, if the child has deteriorating renal functions at the onset, then we would proceed with treatment earlier and then.
Okay.
But
Everything was okay.
But according to the share guidelines, they consider to be a duration of the proteinuria is also considered one of the factors. So unless the child is, I would say hemodynamically unstable or this thing, we would wait for 4 weeks, I think.
Thank you.
Sujata ma'am, would you want to add a comment on, like, if you have a child who has proteinuria but not in the nephrotic range or a low grade, would you biopsy at onset, or we would want to,
It depends upon the severity of the proteinuria and also upon the renal function and also upon the trend of the proteinuria.
Yeah.
And early on, you don't have to instantly biopsy. The heavier the proteinuria, the lower the threshold for the biopsy, but perhaps not instant.
Last case you showed that biopsy showed the C1q, IgA, IgG, IgM and IgA all were positive. So I want to know whether it is HSP or full house pattern. Second, whether in IgA severe nephritis, we should give UHAS protocol. I think whatever the share UHAS protocol, not the 6-dose NIH protocol, because the share guidelines
so
they
this was
recommend
in 2014 when this child had presented, and at that time I think the NIH protocol was commonly used. So that was treated as, and actually clinically we had treated him as lupus nephritis only.
Madam, one question, as a pediatrician point of view, we have a lot of confusion in the treatment starting in HSP. Simple IgA vasculitis coming to us. What is the protocol? What is the methylpred or corticosteroid in the form of prednisolone? What is the dose and how long is the duration? That is a lot of controversy going on. 2 weeks, someone saying 4 weeks, someone saying within 1 week also we can stop it if the child is responding. So what is the guideline? That is the number one. Number two, madam, what are the things we will suspect this child will go to the IgA nephropathy? Initially the child has come to us as a vasculitis, and what are the things in the patient will suspect that this child after long term or 1 year, 2 year go to nephropathy? These two.
Okay. So for the first part of the question, that for the dose of steroids. So as we discussed by Dr. Amita yesterday as well, that now initially we used to always pulse with 2 milligram per kilos, and we as pediatricians tend to use a higher dose of steroids as compared to adults. But what is recommended according to share guidelines is between 0.5 to 1 milligram per kilo, and with severe GI involvement we could taper over the next 2 to 4 weeks.
That is prednisolone.
Yes, oral prednisolone.
What
And
about methylpred?
methylprednisolone we can use a 10 milligram to 30 milligram per kilo based on the severity. So we, as we discussed yesterday, I think sticking to lower dose we're still going to give the same benefit. So if we pulse with 10 milligram per kg for 3 days and then switch to oral, by then we expect the child to be stabilized in terms of GI vasculitis.
Any study, any comparative study of the efficacy of prednisolone versus methylprednisolone?
So with GI involvement, what the issue is, we tend to give, especially with the severe GI involvement, there is a doubt whether the oral bioavailability of the oral prednisolone is affected. So, and these children are often sick. We have kept them NPO. So it is logical to give them injectable methylprednisolone. So that's the thing. And from the IgA nephropathy perspective, at least till whatever I studied for the talk, I have not come across any literature to say that these children who were diagnosed with IgA vasculitis initially became IgA nephropathy. So, ma'am, I think could add more to it.
IgA nephropathy is a totally different ball game. That is only seen in adults. Pathogenesis is similar, that you have deposition of IgA. Otherwise, that's the most common cause of chronic renal dysfunction in adults, actually.
Yeah.
Just a comment here. IgA nephropathy not only is also seen in pediatrics, which is very, very common. in biopsy it is impossible to distinguish whether it is IgA vasculitis or IgA nephropathy. It is virtually impossible. Okay. So in pediatrics, it is IgA nephropathy is also very, very common.
But then clinically, at least they will have only renal limited. No, there are not many studies on IgA nephropathy in children, at least to what I researched. But point well taken. Thank you.
So thank you, chairpersons and speakers.